Alright guys, welcome to our first online only module of the year, and as promised we're going to be going through different types of bacterial infections and talking about treatment plans. First, I'm just going to do some review questions based on the content we discussed last week, and I'll try and pause it here so you can pause the recording and maybe go back to the PowerPoint and look up the answers if you want to try and answer them on your own, and then I'll resume my voice and go through the answer. So question number 1. Which of the following combinations would be reasonable to start if your goal is to provide broad spectrum coverage to include possibly resistant, gram-positive, gram-negative, and anaerobic bacteria? Okay, hopefully you've had a chance to look at the answer. If not, pause it again and go for it. So this just requires you to know which one of these covers all of those things that I told you about. And to be able to translate this into clinical practice is what we're going to talk about during this lecture. But this is really basic stuff about general coverage. And if you know general coverage, you can understand what you need to do as far as treatment goes. So if you know, for example, like pneumonia, generally, a community-acquired pneumonia, we'll use that as an example. Generally, there's a certain group of pathogens that cover that. So we don't usually have to empirically cover for something like MRSA for that. So that's where understanding these coverages really comes into handy and allows you to use your different antibacterial agents to treat different diseases. But in this case, we have a couple different choices here. So let's just go through them one by one. The first is cefazolin plus primaxin, which is imipenem and cilastatin. So this is going to include a number of things it's going to cover, but one thing you're missing with that is resistant gram-positive bacteria. So if I ever use that term, resistant gram-positive bacteria, you can assume that's pretty much MRSA. It's really what we're talking about. You could lump things like VRE, which is vancomycin-resistant enterococcus in there too. But for the most part, what's most relevant to clinical practice is going to be MRSA. It's by far going to be the most common resistant gram-positive. So ANSEF doesn't cover that, neither does primaxin. It's one of the only things primaxin doesn't cover. Primaxin or imipenem would cover your gram-negatives and anaerobic bacteria, though, so you would have that part of it covered. B is vancomycin plus zosyn. This has your vancomycin coverage, or your MRSA coverage from the vancomycin, plus zosyn, which is going to be pretty much the same coverage as imipenem. Piperacillin tazobactam is very similar to imipenem. The only difference, imipenem's got a little bit broader activity and has greater resilience to advanced extended spectrum beta-lactamase producing organisms. So ones that can produce a beta-lactamase that can break down zosyn are usually, well, can be often treated with carbapenem. So that's one of their big advantages. But pretty much the same coverage. So you have very good gram-negative coverage and anaerobic coverage from the zosyn. So B is your correct answer. We'll go through the other two just for the sake of doing it. C, you get MRSA from vanco, and ceftriaxone would have good gram-negative coverage, actually, minus a few things here or there, but it doesn't really have any anaerobic coverage of appreciable value. And D, linezolid, does have good gram-positive coverage, but azithromycin is really lacking on a couple fronts. Its gram-negative coverage isn't the best, and its anaerobic coverage is non-existent, so that would be an incorrect answer. All right, question number 2. Which of the following medications would not be appropriate for an infection caused by Pseudomonas? Oh, I'll pause for a second. All right, so this just requires knowing those buckets that we put together for each, at the end of each major group. So we talked about MRSA coverage, Pseudomonas coverage. We talked about anaerobic coverage and atypical coverage, kind of as some of the more specified subtypes of coverage groups. Now, you might be asking yourself, if you haven't had a lot of training in Med Micro, what exactly is so important about Pseudomonas? And really, when it comes to Pseudomonas, I mentioned that it's an opportunistic pathogen. It's one of the hallmark gram-negative organisms that seems to be problematic in healthcare institutions. Now, there's other things that kind of fall into the Pseudomonas, I wouldn't say family per se, but it's sort of a group. They're Enterobacteriaceae, and things like Enterobacter, Serratia, Acinetobacter, all kind of fall into this nasty gram-negative organism group, which they can just be really difficult to treat. A lot of them have very intrinsic mechanisms of breaking down common antibiotics. So when we talk about Pseudomonas coverage, oftentimes we're including these more not broad spectrum, but more challenging to treat gram-negative bugs too. But Pseudomonas is sort of the poster child for that group of bugs. And as far as testing purposes go, I'm not going to expect you to know like, oh, how do I treat Enterobacter or Acinetobacter versus Pseudomonas? I would either ask you A, what covers Pseudomonas, or B, I would give you specific bacteria with specific resistance patterns to interpret on an exam. And we'll walk through there's some examples like that on the on the cases we're going to go through at the end of the module before the exam, so you get some chance to practice that. Okay, so anyway, A is ceftazidime, B cefepime, C ceftriaxone, D ciprofloxacin. So out of all these, which one doesn't cover Pseudomonas? The correct answer is C. All the rest of them would cover Pseudomonas to a certain degree. Number 3, so you've got patient allergy information, and the question is which of the following antibiotics would be least likely to cause an adverse reaction? The patient's reporting hives to penicillin, a rash to cephalosporin, and tendon pain when they took fluoroquinolone of some kind. So your choices here are Augmentin, cephalexin, ciprofloxacin, or doxy. And so when you're looking at a list of allergies, when you have some things that are a little bit questionable, so penicillin and hives, okay, that seems like a pretty serious reaction. Let's maybe rule out our penicillins right away. So that would be Augmentin would be probably the closest to a penicillin, more or less, and we'd want to take that one out of play immediately. That's probably one we wouldn't re-challenge the person on. When it comes to a rash, rashes sometimes are serious, and of course you don't want to give your patient a rash if you can avoid it. You could pre-medicate them or something, and if it was something you needed to give, you could probably give it. And who knows if they're even going to react to it again. Cephalosporins also, there's some evidence that shows that if you're allergic to a first-generation cephalosporin, you might not be allergic to a third generation. However, that's not a hard and fast rule, so I don't want to really promote that. It's just my point by saying that is that there's a lot of variability within allergic reactions. So when looking at something like this, when it comes to choice B of cephalexin or Keflex, we probably want to avoid it if we can. Now, again, there might be situations where you don't have other options, but here, assuming that these other 2 antibiotics on this list that I gave you would be options for this infection, we're going to move down our list and skip cephalexin because, again, we don't want to risk giving the patient a rash. And my wisdom is that unless you know for sure the patient's tolerated it in the past, you probably want to try an alternative as long as it's still appropriate. Ciprofloxacin is sort of similar to cephalexin. Now, it's not an immune-related reaction. It's an adverse effect that the patient's reporting. Now, tendon pain, is that really something related to fluoroquinolones? Maybe. Remember, there's a risk of tendon rupture with them. But at the end of the day, you have to weigh risk and benefit, right? If this is an elderly patient, they might be more prone to a tendon rupture type event. So it just is something that you may not be comfortable prescribing. What I would recommend is maybe avoiding it, just because if you prescribe it, the patient could also be like, no, that gave me tendon pain. Please don't prescribe that to me. And then they'll think you're crazy or negligent maybe for not reading their chart. So that leaves you with doxycycline, which is choice D. Tetracyclines are not listed on here as an allergy, so that would probably be the safest bet for this patient. Okay, so just some quick review. We touched on a lot of these things last time, but when considering treatment, you want to remember the following things. So source of infection is really important. Your source is going to lead you down the initial investigation towards what bug might be causing your infection. Second, most common pathogens, and again, that's going to be the most common pathogens causing a specific disease. Now, sometimes we have no idea, right? And so then we go broad spectrum, but a lot of times we know generally what we're working with. Recent antibiotic use. So if somebody just had a full course of antibiotics, did they take it all? Are they possibly resistant? Did they, forget to fill it? You always have to check those things. But if they took a whole course of it, that could maybe mean that they have some sort of a resistant pathogen if you don't have culture data to back that up. Previous exposure. Have they had exposure to a family member with strep throat? Have they had exposure to a family member with MRSA or Clostridium difficile, stuff like that? Previous cultures. Of course, you can look at previous cultures. Usually say cultures maybe up to a year out would maybe still be relevant. Once you get older than that, it's questionable whether it's a relevant culture anymore. But up to a year out might be okay to look at still. Certainly more recent things like within the last month or two would be very relevant. Tissue penetration. How well does the drug get to the site of action? That's some of the stuff we're going to talk about today a little bit on a couple different aspects. It really comes into play when you're talking about central nervous system infections and osteomyelitis. So getting drugs into the bones isn't easy, and getting drugs into the central nervous system isn't always the easiest thing to do. Allergies, we just did an example on that, why that's important, of course. Infection parameters, again, reviewing your basic things. So temperature, white blood cell count, what's the culture look like, and how's organ function doing would be all things that could lead you down a pathway of figuring out, what type of infection a patient might have. All right, starting with skin and soft tissue. Cellulitis is infection of the skin, so usually there's a lot of swelling, redness, and heat and pain associated with some sort of a lesion, or it could be an animal bite, it could be some kind of, like like an abrasion that got infected. It could be really anything, but the point is you have a pretty distinct area of inflammation, and that's a pretty common sign of cellulitis. Cellulitis is usually not too hard to treat, and usually it's an outpatient thing depending on how severe it is. Facial cellulitis can be more challenging too, where you can end up with different microbes, and of course if you're affecting things like the orbital socket and the eye are in danger, it might warrant more aggressive therapy. So you'd use your clinical judgment with those types of patients, but for the most part we're going to treat basic skin organisms. So our biggest skin organisms that are almost always going to be problematic for cellulitis are Staph aureus and Strep pyogenes, or group B strep. Staph aureus is probably, from reviewing a lot of these culture data over several years of practice, Staph aureus is almost always the problematic pathogen. But I should give that the caveat with Staph aureus related infections usually contain purulent drainage. So it's maybe a little bit easier to get something to culture if you're doing an IND of some kind, whereas strep infections might not be as noticeable you might not have areas of abscess, so you might not necessarily have anything to culture other than swabbing the skin. If you swab somebody's skin, anyone's skin, you might grow something. It might be staph, it might be strep. A lot of people have this stuff just sitting on their skin, and it's fine because their skin works as a great barrier for things like this. But if you get an opening, that's where your bugs can overgrow and possibly cause infections that way. So MRSA, while Staph aureus can be purulent, MRSA as a recent exposure plus purulent drainage is usually the hallmark towards seeing something that's going to be probably MRSA. So if you're wondering is this regular staph or MRSA? If there's a lot of really purulent drainage, you might want to consider empirically treating for MRSA at that time. For community-acquired MRSA, you're looking at some oral options. So if your patient's relatively fine, other than the fact that they have cellulitis, you want to treat MRSA. Your PO options are your drug of choice. So I've listed a few here, not necessarily in order of which one's best. These all cover MRSA to a certain degree. What I would do is caution you against clindamycin. Not that you can't use it. Clinda has and this again depends on your local resistance patterns. Our local resistance patterns show that clindamycin isn't a really great drug to treat Staph aureus infections. MRSA or not, its Staph aureus coverage is depending on community acquired, might be 80%, and hospital acquired 60%. So it's not the best. Whereas Bactrim or sulfamethoxyl has about 98% coverage of Staph aureus strains. So if you're thinking staph, one of the most popular drugs for skin and soft tissue infection, oral therapy, is Bactrim. That's going to be the drug of choice for most people. Doxycycline also works quite well. Linezolid would be an option too, but there's more side effects. It interacts with psych medications, and you can end up with maybe expensive therapy depending on how much it costs. But again, I think it's pretty cheap now. IV options, you can do doxycycline, clindamycin IV. You can actually do Bactrim IV too. I didn't list it because it's one of those drugs that is notoriously on shortage a lot of times, so it's hard to get. Currently we have it, but certainly you could use it. It's just odd. We don't use IV Bactrim all that much, and I don't know if it's been a cost issue in the past or what, or because maybe it's been out for so long and now it's back, and maybe people just forgot about it. I don't know. But certainly you could use it. But for IV options, I think if you're targeting specifically MRSA, you're going to be looking at vancomycin. I think that's your drug of choice for this. Remember, vanco is a pretty narrow spectrum drug. It really only does gram-positive agents. So where clindamycin has a lot of anaerobic coverage, you're going to do some damage to somebody's GI tract with that by killing off a lot of their natural bowel flora. And doxycycline is a pretty broad spectrum antibiotic that covers a lot of things too. So when in doubt, you want to pick something more narrow spectrum. So that's why I think vancomycin is a good IV option for MRSA. Now, of course, if you don't have MRSA, I bolded cephalexin and cefazolin. We talked about that last week. Those are our drugs of choice for your basic gram-positive. Your first-generation cephalosporins are about as good as it gets when it comes to MSSA, or methicillin-susceptible staph, and all your streps. They're going to cover all of that quite well. You shouldn't really get any resistance. Now, the downside is if you empirically treat somebody with cephalexin for cellulitis, and you culture it, comes back growing MRSA, they will actually not be covered by that, right? So if cephalexin doesn't cover MRSA, someone will have to switch therapies. What I see providers do sometimes, and I don't know, to be honest, how I feel about this, they'll empirically treat people with like a combination. So they'll do Bactrim plus cephalexin for oral therapy. And what that gives you is your bases covered. So you're covered if you grow MRSA, and you're covered if you have the basic gram-positives. And again, I don't know how much I agree with that. I think ultimately, if you're strongly suspecting MRSA, I'd probably just go with the Bactrim and call it good. I can't tell you how many patients I've had to call and say, hey, you can stop taking your Keflex that you've taken, 5 days of already. So you've basically been taking an antibiotic for no reason. And that's not necessarily something we want to be doing, right? We don't want to be giving out antibiotics that aren't working or doing anything for people. So just some food for thought there. And that's what this combination therapy point is on. Incision and drainage, if you have something with an abscess, that's the gold standard for treatment. And there is actually some data that shows that if you do a good IND on somebody, you don't necessarily need to treat them with any antibiotics whatsoever. A lot of people do anyway. And so it's going to be up to you and how severe you think the cellulitis was. But it wouldn't be inappropriate to do an IND and just discharge somebody from your urgent care ER or from your clinic, send them home without an antibiotic. A lot of people will do cephalexin. I think it helps people sleep at night knowing that you can suppress some of those basic gram-positive that might get back into that abscess and reinfect it potentially. So just depends on how aggressive you want to be. Either way is fine, but you guys will probably cover IND a little bit more in ClinMed, so I'll leave that kind of up to them as far as what types of decisions they want to go over there. Treatment length is usually about 7 to 10 days for cellulitis. Some other considerations to think about with skin and soft tissue: puncture wounds, anything that's penetrated through a shoe or been contaminated could possibly have all kinds of stuff on it. If you step on a nail and it goes through your shoe, you're looking at a whole variety of possible microbes that could be in that particular infection. So you could maybe expand the coverage to include something like Cipro, which would cover Pseudomonas. Pseudomonas is notorious for living in water, so anything that's wet could possibly have Pseudomonas in it, and there you go with a Pseudomonas infection in the bottom of your foot because you stepped on something really sharp and it went through your shoe. And of course, the bottoms of shoes are quite dirty too, so you can use your imagination to think of what you might do. A lot of times when you get these weird situations, sometimes it's okay just to treat them basically and say, you got a cut with a really nasty tool that was really dirty, but we don't really have any evidence to say that there was something on that tool outside of the normal, so we might just start you on Keflex or a Bactrim or something and see how it goes, and then we can always add therapy or change therapy later. That's not a bad idea either. Sometimes it's hard to figure out empirically how to treat somebody if you have no idea really what you're approaching, and that's what it is when you get some of these weird cuts and puncture wounds from like a dirty tool or something. So what I'd recommend again is maybe sticking to the basics, and you can always expand therapy. Of course, if somebody's really sick or not improving or they get worse fast, you could do it more aggressively. But I think sometimes just sticking to the basics and not trying to get too fancy with your recommendations is okay. But certainly if you have like a wet shoe and somebody's walking in a lake and stepped on a shard of glass or something that went through their foot and it's infected now, maybe Pseudomonas coverage like with Cipro might not be a bad idea. Something to think about. Animal bites. You're looking at Pasteurella multocida as the organism that is in animal mouths, and usually the drug of choice here is going to be Augmentin, and that's pretty much for any animal bite you'll encounter. So dog and cat bites are most common just based on being common pets. There's a lot of other bites that could possibly have different implications. So the Sanford Guide actually is a really great reference for animal bites if you use that particular reference. Otherwise, again, it's mostly Augmentin. There are animals that can carry rabies. The Minnesota Department of Health has a pretty good guide on bites and what type of animals might have rabies, and you might have to vaccinate or give immune globulin for that. But that's a different topic, so we're getting off the beaten path a little bit. But the point is that animal bites, augmentin, because augmentin has good general okay like skin bug coverage, so you're going to get like your streps covered. It has some MSSA coverage. And then it covers Pasteurella really well too. Cat bites are notorious for causing infections. Cats have really sharp, long teeth that dig deep into the skin. Dog bites, on the other hand, rarely actually get infected. Even though dogs have powerful jaws, they just don't have as sharp and long of teeth, so they don't seed the bacteria deep into the skin. People generally don't get infections or cellulitis from dog bites. Cat bites are much more common. If we get a little bit more advanced into our wounds here, diabetic foot ulcers are usually long-term neglect. So you got some sort of a injury to the foot at some point, and because diabetic patients who have advanced diabetes might have limited feeling in their feet due to neuropathies or nerve and blood vessel damage over time due to uncontrolled diabetes, you can end up neglecting certain things, and so you end up with a really nasty infection. Usually these are quite deep, and they have lots of different bugs in them. So you're usually looking for broad-spectrum antibiotics when you treat these patients, because you're probably dealing with gram-positives, gram-negatives, and likely anaerobic infections too. So pretty much for a standard diabetic foot ulcer, you're going to want to cover those items. So like a vancomycin Zosyn regimen would be something that would probably be indicated for a patient in this situation. If you have bone involvement, then you're looking at adding some sort of looking at osteomyelitis treatment, which we'll talk about here in a second, or right now. Similarly treated to skin and soft tissue infections for bone infections, not a ton different. Usually your organisms aren't all that different, but it's more serious. It requires IV therapy. It's hard to get enough systemic exposure with PO to treat bone infections. However, some drugs will be okay, like fluoroquinolones are an example. Linezolid might be able to be taken orally. The one big problem with bone infections is the length of treatment. You have to treat for like 4 to 6 weeks. So that changes a little bit of your game plan, because usually when we're treating with antimicrobial agents, we're talking about short courses, so long-term side effects aren't really an issue. In the case of osteo, you do have to consider that. So like fluoroquinolones in the short term usually are okay. If you take them for a long time, I didn't really talk about this last week, but they can mess with things like they can alter blood glucoses, so diabetic patients might get some insulin resistance, or might get their morning blood glucoses way out of whack that they aren't used to seeing. Another thing you might see is with the fluoroquinolone class is something that came out recently. Well, not recently per se, but it was a recent black box warning added to fluoroquinolones about peripheral neuropathy and central nervous system effects, which is a little bit vague, but there could be a possible risk for that too over time, that they might have some neurotoxicity for them. So it's, again, something to consider maybe about using these long term, not the greatest agents. So these are patients where you'll see them coming in and out of infusion centers for a month at a time because they're getting vancomycin twice a day. Linezolid is an option too, and again, I think you can take that orally. Some ID providers, I just don't think trust oral blood concentrations. I don't think you can get high enough blood concentration to really get adequate bone penetration, and that's just a provider preference sometimes. Clindamycin also gets pretty good bone penetration, and most cephalosporins do too. So you've got plenty of options. It's just a matter of tailoring them to the specific organism you're treating. Empiric therapy for somebody with osteomyelitis, like vancomycin plus levofloxacin or advanced generation cephalosporin. Usually vanco is something you're going to start until you can rule out MRSA. Once you rule out MRSA, you can drop the vanco. And then again, a fluoroquinolone plus a fluoroquinolone, or not in addition to, you do one or the other, advanced generation cephalosporin. And the cephalosporin is going to depend on what you're looking at. So if you've got a cefepime on board, that's probably for some sort of advanced resistant gram-negative like Pseudomonas, whereas ceftriaxone is going to pick up pretty much everything else. Ceftriaxone is a great drug for a number of reasons that we talked about last week, but a nice situation here is that it's for osteomyelitis for long-term treatment. It's once daily. Ceftriaxone not only covers gram-negative agents well, it also has pretty good MSSA coverage. It has good strep coverage, so it's going to cover skin pathogens quite well too. It doesn't have MRSA coverage, but you get a nice compromise here, whereas Ceftaz or Cefepime are going to be 3-4 times a day dosing, which isn't ideal. So there you go with why we do some empiric therapy here. Levofloxacin, once daily medication there as well, so that can be a more convenient option for patients. You often have to do there's a lot of testing involved with osteomyelitis that I'm not going to go through, but bone biopsies are usually the gold standard, and you can do that and then test that for specific bacteria and then narrow your agent off of that. Derm uses, we're going to talk about this during acne, so I'm not going to go through this specifically right now. Okay, moving on to ENT indications. I don't have a ton to talk about here because most ENT-related things are viral, so they don't generally warrant antibiotic treatment. Not to say we don't do that, but your standard organisms are all kind of the same, and you're looking at viruses as the most common cause again, and strep pneumoniae, H. flu or Haemophilus influenzae, and Moraxella catarrhalis are the three big ones as far as bacteria go. Rhinosinusitis should almost never be treated with any antibiotics. Sometimes if you have somebody who's been, they've had a rhinosinusitis for a couple of weeks, it's probably started as viral, maybe now it's bacterial. I know it's difficult to diagnose that, I think, from my perspective, because it's often going to be viral, but maybe there's a bacterial co-infection there too. I don't think you can always tell, but you can definitely have it occur. However, studies will say that it's less than 2% chance. So for the common cold, you should almost never be prescribing any antibiotics. Now, if you did, you're looking at Augmentin, amoxicillin clavulanate, because that covers your streps really well. It also covers some of the anaerobic bacteria that might be in the kind of upper airways that are getting in there from the oral, from saliva or whatever, from the oral pathways as well. There's some alternate agents there, but Augmentin usually should be good. You'd only really go to an alternate if you had a failure of Augmentin, or you could be looking at a possible allergy of some kind. Short course, a lot of people with general upper respiratory tract infections get antibiotics, and as you can see, based on the incidence of actual bacterial infections, this is probably one of the biggest areas of inappropriate antibiotic prescribing we have. So when it comes to ENT infections, it's not always going to be very beneficial for the patient to take an antibiotic. It's probably not going to help them. It puts them at risk for things like C. diff, and you end up with no improvement in their symptoms. So, I understand that it's difficult to explain this to patients, and patients are insistent sometimes. But there is a point where stewardship is important, and I think that this is a big area where we can make improvements as a healthcare group and as a country, really. I think this is a big problem nationwide, so certainly something worth striving towards, I think. With tonsillitis or pharyngitis, you're looking at group A strep as the primary bacterial culprit, so you can do a rapid test to see if there's positive for strep, and then you can do a throat culture too. If you do a throat culture, you might see not only group A strep, but you might see group C or G. Group C and G strep are normal flora, and even if somebody has treatment, has symptoms, you shouldn't really treat them. People will resolve on their, the symptoms will resolve on their own, and there's really no reason to give somebody antibiotics for these. They just won't benefit from them, really. The reason why we treat group A strep is that not because it's a nasty infection. In kids it can be problematic, but for the most part, there's a rare risk of something called rheumatic fever. So essentially what rheumatic fever is an antibody development of that the body makes by reacting with a toxin that group A strep produces. So the idea is that by actually treating it, you're limiting that risk. I work with some cynical physicians, and one of them says that you're more likely to give somebody anaphylaxis by prescribing them penicillin than you would to be preventing rheumatic fever. So he'll never treat this. But generally the guidelines say you should treat group A strep because of this, and especially in kids and young adults and adolescents. Once you get into later adulthood, or even outside of adolescence, it's probably not a huge deal. And again, the symptoms are going to resolve on their own over time. Treatment is standard penicillin. We usually give an injectable for 1 dose. You can also give oral for 10 days. There's alternatives available: amoxicillin, azithromycin, pretty much any cephalosporin. Everything's fine. I put Ceftonir down here. Ceftonir actually comes as an oral suspension that tastes really good. So for kids, that might be an option. Cephalexin would be just fine too. For any generation of cephalosporin, we'll cover group A strep. You could have anaerobic infections too, and if you have like a tonsillar abscess or something. Clindamycin is generally good for stuff like that. If you have dental abscesses or anything that's involving, the mouth flora, it's going to cover those anaerobes. Azithromycin can add some atypical infection control too, possibly, but it would be an odd situation where you'd actually need that. Clindamycin would be a more common, thing to add on here. Otitis media, so control pain, and then you have 2 strategies. You have wait and see, which would be observed for 48 to 72 hours. And then, you have the screaming kid, so your parent's going to agree to that. Or maybe they've been good parents and they've been, not to say bad parents bring their kids in right away, but maybe they've been appropriate parents and they've waited 48 hours after symptoms started, and then they brought their kid in. Now, no, they aren't getting better. I think we should consider treatment. Anyway, you're looking at pretty standard ENT bugs. Amoxicillin is the gold standard here, and most kids will respond quite well to that. There's some alternatives there for allergies or failures in treatment. If it recurs within 30 days of a course completion of amoxicillin, you probably want to try a 3rd-generation cephalosporin. You could go to levofloxacin, but that has some issues with kids. So in adults, it might be okay, but kids, we generally try and avoid fluoroquinolones. We'll talk about that more during pediatrics, though. And topical therapy. If somebody has like otitis externa or a ruptured eardrum, then you can try topical eardrop. Cipro comes as an eardrop, and that's probably the drug of choice for topical otic therapy. And ophthalmic infections, conjunctivitis. This is a debate about bacterial versus viral. You're usually looking at your standard ENT bugs, but Staph aureus is pretty common in adults too. There's a lot of antibiotics that come as topical eye drops: erythromycin, polymyxin, trimethoprim drops, fluoroquinolones and azithromycin drops come in too. And I think you generally start with either an erythromycin ointment or a polymyxin trimethoprim drop. Those are quite cheap and easy to get. The fluoroquinolones can be expensive, and you could depend on what's going on. So sometimes Pseudomonas might be an issue, especially if somebody has contact lenses, so maybe a fluoroquinolone would be better for that. And Cipro comes like that. Moxifloxacin comes as an eye drop as well. Okay, moving on to pulmonary infections. So if you work in urgent care emergency department, or if you go into like an internal medicine service in a hospital, this is going to be a bread and butter thing you're going to have down pat. And outpatient too, of course, is important. You'll see this in the clinics too, and I think understanding how to triage people appropriately is good. But we'll talk about every different aspect of pneumonia here, and to the point where your probably head is going to spin thinking about pneumonia. However, I don't think it's all that hard. I just think there's a lot of rules about how to do it. So try to look at the big picture here, and I'll hopefully point that out for you. So community-acquired pneumonia. It's pretty similar to ENT, strep pneumo, respiratory viruses, and atypical pathogens, plus H flu, MCAT, not so much. You're going to see as your primary thing. So atypicals are mycoplasma, chlamydia, pneumonia, which is different than the STD chlamydia. It's a respiratory pathogen, and Legionella. Out of those 3, chlamydia and pneumonia is not super common. Legionella is not super common. It's more associated with weird water reservoir outbreaks, like things, not reservoir per se, but I mean reservoir like as in pooled water somewhere. Like you'll see it with like bad cooling systems. It's kind of historically what happened with Legionella. Anyway, mycoplasma is the most common one, and as far as the atypicals go. So when we're looking at outpatient therapy with community-acquired pneumonia, you can look at a couple different options. So you can use azithromycin as monotherapy if your local resistance to strep pneumo is greater than 25%. This is per IDSA guidelines. Now, if you can find a place in the United States where azithromycin is greater than 25% susceptible, I'll be really surprised. So basically what you should think about immediately is that you can never use azithromycin for any patients with community-acquired pneumonia. You just shouldn't even really consider it. Here locally, we have about a 50% resistance rate to azithromycin, and I think that's pretty common around the country. So let's rule that out right away. Now, I have had some providers tell me that, well, you can diagnose atypical pneumonia from a chest x-ray. And I'm not going to talk about diagnostics. That's not my thing. But I do know that we actually brought that to our ID task force in the hospital and talked about it with our infectious disease specialist and our pharmacist infectious disease specialist, and all of them agreed that that's actually not a real thing that you can do. So you can't diagnose somebody and know for sure that they have an atypical pneumonia. If you did, yeah, great, azithromycin would be fine. If you could totally rule out strep pneumo, but strep pneumo is a super common community-acquired pneumonia pathogen. So certainly you need to cover for it, in my opinion. So azithromycin monotherapy is a no-go. Doxycycline has pretty decent strep pneumo coverage, it's about 90%. And it is a nice option, I think. So if you have a healthy person that doesn't really have any history, one reason I really like doxycycline is because it doesn't have a lot of drug interactions, less so than some of the other options. So when we move on to some of the other items, so specifically when you add comorbidities, including pretty much any type of disease. Now, comorbidities it's not like, so when you look at this, it's not like somebody has to have comorbidities to use this tier. This is actually going to be a very common tier for pretty much anybody presenting with community-acquired pneumonia. Fluoroquinolones, levo or moxifloxacin are by far and away the favorite drugs for these. And I think they actually are quite appropriately used for this type of a therapy. And this is really where these drugs shine, in my opinion. They're once daily, they're great for outpatient treatment, adherence is good, and with Levaquin, you can do 750 milligrams once daily for 5 days only. That's a pretty sweet treatment. They've shown that that's just as effective as a 7 or 14-day course. So again, you get once daily, 5 days, and that's your whole course. So it's very popular, it's very effective. Levaquin has great, and moxifloxacin too. They both have great coverage. The only difference is with that levofloxacin, with the high dose, you can get by with a shorter course. Now, you can use azithromycin still, but you have to couple it with something that covers strep pneumo. So azithromycin has great atypical coverage, but you have to add strep pneumo coverage, which would be a second or third generation cephalosporin. So a lot of times what you'll see is ceftriaxone used. Ceftriaxone I put in here just because you could give somebody like a shot of ceftriaxone, an IM shot, and then prescribe them ceftriaxone orally. You could also do ceftonir, which would be another third-gen cephalosporin, would be fine too. Or actually the guidelines say you could add augmentin or high-dose amoxicillin even to azithromycin. So there's a number of different options there, but what's commonly done is either the fluoroquinolone choice or azithro plus the cephalosporin. That's where I'd be more comfortable as opposed to like high-dose amoxicillin or augmentin personally. But when you're doing those, you're looking at least 7 days and maybe up to a 14-day course. So you don't get as short of a course as you do with like the levofloxacin. So it's just some food for thought. The reason why that this is under specific comorbidities categories, it's that those patients are maybe going to be more likely to have resistant pathogens. So you want to make sure you're more likely to have severe effects from the pneumonia as well. So you want to make sure you're treating them more aggressively. So in the case of the doxycycline not having, possibly a 10% resistance rate is not good enough here. So we want to make sure we're a little bit better than that. But you have several options here to choose from. Okay, admission to the hospital. It's very similar. Really, what we're still doing here is we're trying to cover atypical pathogens and we're covering strep pneumo. When it comes to a non-hospital ICU admission, you can do fluoroquinolones, the same ones, either oral or IV. Oral is just fine for hospital, especially if somebody's not that sick but needs to come in. Maybe they're just sick enough or you don't want to discharge them, but they're tolerating orals just fine. Go ahead and give them oral medication. Azithromycin plus third-gen cephalosporin. We'd probably almost always do ceftriaxone in the hospital just because it makes the most sense. It's once daily dose, it's cheap, it's effective. But you could do the azithromycin oral as well. If you had somebody who was allergic to a third-generation cephalosporin or had an issue with cephalosporin, carbapenems can be used as alternatives to cover the strep pneumo. So ertapenem is an alternative. You could use IV Unison, which is ampicillin sulbactam, in place of a third generation cephalosporin too. But I wouldn't be a big fan of that just because it's got pretty significant anaerobic coverage. So you're going to have a little bit more effects on the GI tract than you might need. You don't really need to wipe out somebody's GI flora if you don't have to. So in this case, I would recommend avoiding it. But it is an option and it is okay per the guidelines. But I would stick to those first 2 bullet points here and you're going to be just fine. It's going to cover the majority of your patients. The really nice thing about this whole setup is, the most common allergy you're going to see to antibiotics that are really commonly used is going to be your penicillin. So, if you get your penicillins wiped out, that leaves you with your fluoroquinolone as a side option here. So you have 2 very different antibiotic classes that you can rely on here, and that's going to cover most patients by far and away. And then, of course, you do have the carbapenem if you need to fall back on it too. So if somebody's going to the ICU, we treat them a little bit more aggressively. So we're just basically, it's very similar. We're going to do everything IV though. And the big difference is we don't use fluoroquinolones by themselves. So fluoroquinolones sort of take the role of azithromycin. We basically say, all right, fluoroquinolones, you have to be kind of the atypical coverage here. And then we're going to add on a third generation cephalosporin. So again, ICU, big difference, IV only for everything and no fluoroquinolone monotherapy. If you had Pseudomonas concern, like if your patient had been in the hospital recently or immunocompromised perhaps, you could do a Pseudomonas covering drug like imipenem, piperacillin, cefepime. You still need to cover your atypical pathogens. So these are going to cover Pseudomonas, plus they're going to cover strep, pneumo, and all that other stuff. But they don't cover atypicals. So you have to add Cipro or levofloxacin. We usually don't use azithromycin just by itself here as an atypical coverage. So the idea here is a couple things. So this gets a little confusing because when you have somebody who has a Pseudomonas risk and they're got some sort of a pneumonia they're being admitted for, you have to double cover both things. So you want strep covered by 2 different agents in different classes, and you want Pseudomonas covered by 2 different things. So your first group up here covers both strep and Pseudomonas. The second group covers both strep and Pseudomonas. So you're good with this line. Or you can add azithromycin, but azithromycin doesn't really cover strep. So you have to add an aminoglycoside on board too, which almost is never done. So it gets really confusing. And honestly, that double coverage concept is a guideline related thing, and it's not necessarily proven. And there's a lot of studies that say it doesn't really help to do double coverage. So some institutions, a lot of institutions don't do that. But it is something that I wanted to say because it is in the guidelines. So it is something worth knowing. But know that double coverage is a little bit of a controversial topic. And of course, if you had MRSA concern, history of MRSA, immunocompromised patient, recent hospital exposure, you could add vancomycin, or if they have allergies, you could add linezolid to any of those above regimens to add that extra coverage. HAP or VAP is either healthcare-associated pneumonia or ventilator-associated pneumonia, and they're kind of the same thing. There used to be something called HCAP, which is healthcare-associated pneumonia, which has fallen out of favor, and that was sort of like for the in-between people, like if somebody was in a nursing home. But basically, studies have shown that those patients respond really well to standard community-acquired pneumonia treatment. So for somebody in a nursing home, we don't need to treat them any differently than we would really anyone else. So with HAP or VAP, that's a little bit different because this means that they actually got the infection in the hospital. So it's like somebody who came into the hospital just fine, developed a pneumonia during their stay, or they got put on a ventilator for another reason and developed a pneumonia because of that. So the chances are that there's something nasty growing in there and maybe something hospital acquired, which could be resistant things that like to live in hospitals like MRSA and Pseudomonas. So it's really broad spectrum therapy. We're going to use vancomycin and a drug that covers Pseudomonas like Zosyn or imipenem or cefepime. And culture it, de-escalate as needed. So if you don't grow any MRSA, then you can probably get rid of the vanco. If you don't grow any gram-negatives, you can maybe get rid of the Zosyn if you can isolate like MRSA. So again, some people will like to double cover that Pseudomonas with 2 agents. They might add on a fluoroquinolone to your vanco and Zosyn, so you'd add maybe levofloxacin on, but not necessary in all cases. COPD exacerbations are kind of like a mini pneumonia, and actually there is some evidence that just azithromycin by itself works decent. So usually you use one agent. You use azithromycin, you can use cephalosporin by itself, or doxycycline. Some studies have shown that Bactrim actually works pretty well. Bactrim, while it doesn't cover skin-related strep, it does cover strep pneumo, a little bit confusing there. If it's more severe, you can up your ante to a fluoroquinolone, and then do the same things, IV fluoroquinolone or cephalosporin. So COPD exacerbation is basically like a CAP, but a little bit shorter of a treatment course and less aggressive therapy. Okay, endocarditis is something that I'm just going to go over briefly. It's really, I think it's pretty confusing, so I don't want you to spend a ton of time on it. Basically, somehow there's bacteria floating around in the blood that get into the heart valves, and they grow there. They cause a vegetation on the heart valve. And what can be really risky is that vegetation can end up causing some blood pooling, and you can end up with these growths that end up breaking off, and then you get a clot that goes up through the valve and into the aorta and into the brain or something, and you get a stroke. So there's lots of risks with this, and of course, if you have some vegetal growth of bacteria in your heart, you can end up with constant bacteremias and sepsis and stuff like that. It's really nasty. Most people who get these have either damaged heart valves, or they have an issue with a dental procedure. Actually, dental procedures in older people is a common source of endocarditis. And then for young people, IV drug abuse is going to be the big thing you're going to see here, because people are injecting weird stuff into their body that they don't realize they're injecting when they inject drugs. Complications include bacteremia, and again, infections, stroke, possibly heart failure if the heart valve isn't functioning. So again, you get a vegetal growth in the valve, and then it just impairs the ability here, and then of course that can go throughout the whole body as the blood circulates through. Usually we're looking at gram-positive bacteria, so strep viridans and Staph aureus are going to be the most common ones. And then you've got a whole slew of different things like Enterococcus, coagulase-negative staph, which is usually just something that lives on your skin and isn't a pathogen. But if you inject it into your body, sure enough, it can become that. And Hasek organisms, which are a group of gram-negative things that are all kind of weird, but you see them associated with endocarditis, specifically usually IV drug users who are injecting. So criteria, again, I don't really care you know all this for the exam, but I figured I'd put it on here. Prosthetic versus native valve makes a difference. Usually prosthetic valve requires longer duration of treatment. Blood cultures are going to be positive, so we can try and sometimes even if somebody has suspected endocarditis, because you're taking a really broad approach to this. If you treat it empirically, you don't really know what you're targeting. So if you can wait for a blood culture to come back, you can actually just, okay, well, this patient's not immediately in danger of dying. Let's wait for a blood culture. Let's see what it comes back as, and then let's tailor our therapy towards that, as opposed to giving somebody the kitchen sink and then pulling back. So it's not a bad approach, and sometimes they do it that way. But for most patients, you're going to look at broad spectrum therapy, so staph, strep, enterococcus, and then usually you're probably going to have some gram-negative coverage on there too. So like a vancomycin, ceftriaxone, vancomycin cefepime, vancomycin zosyn would be all probably okay for this. But again, you don't really know what you're targeting. For sure gram-positives, but there's also that risk of that gram-negative issue too. And so here's just some examples. What I want you to know for this are a couple things that I think are worth taking home. First of all is that gram-positive treatment is going to be key for endocarditis. So covering staph and strep, which is pretty much going to be vanco, or some other things potentially. But vancomycin is going to cover both of them. One thing I'll just point out is a drug called rifampin. So anytime we have anything that's prosthetic that gets some sort of an infection, and this would go for like a prosthetic hip or knee that got infected as well from post TKA or post hip replacement, you get these vegetal growths. And the thing about rifampin is it actually works well as a biofilm penetrator in these areas. So do like to see it added to some of these. So if you have somebody with a prosthetic valve, that's going to be a good agent that they're going to throw in there. Rifampin is also an anti-tuberculosis drug, but it also gets some play here. It's never used by itself, but this is a weird area to remember. I think that rifampin has a role. Especially if you work in ortho surgery or work in CV surgery, you may see this with prosthetic valves getting infected or prosthesis getting infected. And rifampin is something that's used in those cases. So again, I think it's kind of a weird drug that we didn't talk about last week because it has very minimal use in most people's day-to-day practice. But I think this would be worth remembering. All right, CNS, bacterial meningitis is pretty rare, but it's super fatal and serious. So we treat it very aggressively. If you don't treat it, I can't remember what cases. I think it's pretty high rates of fatality if you don't treat bacterial meningitis. But why wouldn't you treat it if you knew it was happening, right? So bacterial meningitis, headache, fever, stiff neck upon presentation. A lot of cases are viral or aseptic meningitis, which isn't as serious. But you always want to do spinal tap and consider, other bacterial sources. Cerebral spinal fluid should show you a bit of a trend if it is bacterial. So you should see decreased glucose, increased protein, and really high white blood cell counts. So those things. And I always remember this, that if you have bacteria floating around in your CSF, they're probably eating glucose because they want energy. And the proteins are probably because they're producing metabolic byproducts that could be proteins or toxins or whatever that's picking up. I don't know if that's actually true. That at least helps me remember that in case you're wondering, for a little tip there. But the really high white blood cell count is a hallmark thing. And that's also associated substantially, I think, with strep-related meningitis. Once you get your CSF and blood cultures, you really need to get the antibiotics started right away. And because we're going into the central nervous system across the blood-brain barrier, we have to be using really high-dose antibiotics. Penetration is super important. So this is a chart that shows a lot of things, and you might be looking at this saying, wow, that looks really confusing. Well, it's not too bad. The thing I want you to remember, I'm not going to test you on the kids, so don't worry about that right now. But kids are pretty much the same as adults. Really, we're using third-generation cephalosporins and vancomycin as our backbone. It's going to cover the two major pathogens, which are strep pneumo here and Neisseria meningitidis. Once you get over 50, you have some other risks. So listeria, E. coli, especially for really older adults, like maybe like elderly patients. So what they'll do is they'll add ampicillin. The reason is that ampicillin covers listeria really well, and it gets into the central nervous system really well. Whereas Vanco is going to be covering pretty much everything. It's going to work well, but it doesn't get into the central nervous system as great as we like. And third-generation cephalosporin like ceftriaxone would do really great to get into the central nervous system. It covers gram-negative bacteria. It covers strep pneumo. So you get a lot of good effects from it that way. So really, it's just basically 3 drugs to remember for this. Vanco plus ceftriaxone, and then if you're over 50, you're going to add ampicillin. So this whole chart can be summed up in that one sentence I just said. Sure, there's all this head trauma stuff down here, which I'm not going to test you on. Basically, the idea is that if you had some sort of penetrating trauma into the brain, you're looking at maybe a bunch of different organisms. So usually you just extend your spectrum. So here we're adding cefepime to cover Pseudomonas and other gram-negatives. So that's really all there is to that. There's not much more. Granted, very serious infection, but pretty easy to treat, I think. At least from a antibiotic standpoint, there's only a couple things we actually do. If you're wondering what covers what, this table I think puts it together nicely and shows you some alternative therapies too that you could consider trying. For people who are allergic, we've used meropenem before in really pen or cephalosporin allergic patients. So you see that every once in a while, but for the most part, these are the standard agents we're going to use. All right, GI. Helicobacter pylori was discovered as the common cause of ulcers and peptic ulcer disease. And it does require antibiotic regimens for eradication. The standard therapy is called triple therapy. It's amoxicillin, clarithromycin, and a proton pump inhibitor, which is like Prilosec, Nexium, Protonix. All those drugs are proton pump inhibitors. A lot of them are over the counter now. If somebody is pen allergic, you can substitute metronidazole for amoxicillin. Metronidazole, we talked about it as an anaerobic agent, but it does have pretty good Helicobacter coverage. If the standard of practice is that somebody would try triple therapy first. If they fail, they'd usually go to quadruple therapy, which is metrotetracycline plus the proton pump inhibitor. And the fourth agent is not another antibiotic, but it's Pepto-Bismol, which is bismuth sulfate or bismuth salicylate, excuse me. And actually, Pepto-Bismol does maybe theoretically have some antimicrobial activity in the GI tract, but it's not like you're adding another big gun antibiotic on. It's just kind of switching up the therapy a little bit. Failure rate's not uncommon, 20% first-time failure. And again, if triple therapy, try quadruple. There's this other thing called the load therapy, which involves levofloxacin and a bunch of other stuff, which I'm not concerned you know. I've never seen it done. But you are supposed to confirm eradication with additional testing. With most patients, probably take this and then never actually get that done. But I suppose if the ulcer really bothers them, they would do that. And here's just an algorithm to show you how to treat it, in case you want to look at it more visually. Okay, intra-abdominal infections. Again, I've got a bit of a confusing chart, but I really like it because I think it's pretty comprehensive, and I'd spent some time just reading over it. This is from the IDSA guidelines. The thing to remember about intra-abdominal infections is really you want to cover for your basic intra-abdominal infection. So let's stay in the mild to moderate severity category here, and we're going to avoid pediatric. We don't care about them right now. We're only talking about adults. So in mild to moderate severity, really all we want to do is cover E. coli and Bacteroides. E. coli being our archetypical gram-negative bacteria, and then Bacteroides being our archetypical anaerobic bacteria. So we can do that with monotherapy via any of these agents listed here. So pretty much cefoxitin is going to be the preferred one. Ertapenem is fine. It's just really expensive, and you cover a lot of things you don't need. It's really pretty broad spectrum for what you need here. Moxifloxacin would be okay. Tigecycline we talked about not really being used, and ticarcillin we talked about no one really uses that too much either. So more commonly what you're going to see is a combination therapy. So usually what people like to do is one of two things. The most common one is ciprofloxacin plus metronidazole. In case you're wondering what I'm talking about with intra-abdominal infections, this would be like moderate appendicitis, diverticulitis, things like that. So the reason why people like Cipro and metronidazole is because it's easy to convert to an oral regimen from IV, but Cipro doesn't have the greatest E. coli coverage. It's probably in like the mid-80s as far as what percentage is susceptible. So what I like to do is do ceftriaxone and metronidazole, because ceftriaxone will cover pretty much any pathogenic E. coli. So E. coli is going to be an opportunistic pathogen, lives in the GI tract if you have some sort of an inflammation. There's some probably E. coli problem going on there. It's worth treating, I think, with something that for sure is going to cover it. So that's why I like ceftriaxone in this case. High risk or high severity. So these would be like people with a ruptured appendix or really more advanced disease, immunocompromised, older patients. You're really going to just broaden your gram-negative coverage, and you're going to cover with something that has pseudomonal coverage. So remember, most of our pseudomonal agents, with the exception of cefepime and ceftazidime, cover gram-negative or cover anaerobic species quite well. So piperacillin, tazobactam, and imipenem or any of the penems will do quite well here. You can also add metronidazole on. So remember what I said last week, that cefepime basically becomes an equivalent to piperacillin, tazobactam, and imipenem if you add metronidazole to it. So that's where you have this option here. So you could do cipralevaquin as well, but most people in advanced infections would do like a cefepime. This would be a patient, I think commonly you'd see would be having an intra-abdominal infection and looking maybe septic, starting to look that way. You'd want to treat them with maybe something more aggressive here. For the bottom chart here with biliary infections, it's really just less initial for moderate to mild severity patients. So for your basic infections, you're going to be looking at similar things. You want to cover gram-negatives, but you really don't care about anaerobes as much in the biliary tract. Once you get more significant infections, that's where you would add on that anaerobic coverage. Clostridium difficile, I've talked about this a couple times. This is a really common healthcare exposure, and with antibiotic use, it can range from really mild diarrhea, frequent diarrheal episodes, to severe colitis, which can be profuse diarrhea, hemorrhagic potentially, and septic even in some patients. We want to stop our offending antibiotic therapy as soon as possible. In some cases, this might not be possible to do. Like if somebody has got a septic infection from another site and they get Clostridium difficile, we might just have to treat through it because they're going to need systemic antibiotics continued. But if we can stop the offending agent, or maybe change to a more C. diff friendly agent, so things that don't cause C. diff quite as much, aminoglycosides, sulfa drugs, macrolides, tetracyclines, vancomycin, much less likely to cause C. diff. Everything else may or may not. I like to think the things that have more anaerobic coverage cause it more frequently. So your extended spectrum penicillins like amoxicillin clavulanate, ampicillin sulbactam, piperacillin tazobactam, your carbapenems, clindamycin. Metronidazole would not. Metronidazole is actually treatment, so which is down on here. So the first line treatment for C. diff is oral metronidazole, usually for 10 to 14 days, and especially if the initial episode is mild. If somebody's initial episode is severe, you can go straight to the second line therapy, or if they failed metronidazole course, you'd go to vancomycin, and usually you're giving this oral 4 times a day. Vancomycin comes as an expensive capsule called Vancocin, but most pharmacies compound it, or there's actually a compounding company that makes like a powder that you just mix a diluent with, and then you get your oral vancomycin that way. It's a really nice option. It's way cheaper than the capsule, so I highly recommend prescribing the oral liquid if you're going to prescribe for vancomycin. Just a little tidbit to remember. The dosing is standard if you look it up in like a monograph, but you'll see doses all over the place, and a lot of people with C. diff, a lot of ID providers will get referred cases of really resistant C. diff, so you'll see things like really complicated tapers or cyclic therapy where they're on it for a few weeks off and then on it again. I've seen chronic vancomycin for suppression, believe it or not. And then ultimately you could try fidaxomicin for vancomycin resistant cases. It's unusual. It's not commonly done, but and I don't think there's great evidence that it's all that much better than like trying a vancomycin long-term taper or something like that. Probiotics aren't shown to have any benefit for Clostridium difficile. Certainly not going to hurt a patient, but haven't shown to improve outcomes. And fecal transplant is something that's new, where you actually take a stool sample. Usually it's of a relative or a loved one, somebody you live with who might have a similar GI flora as you would. And then what they do is they process it somehow. They put it into, I don't know, capsule form, or I don't know, sedate you and put a tube down your throat and then transplant the fecal matter that way. I don't know. It sounds gross, but it's been getting more and more common, and I actually think this was pioneered in Duluth, believe it or not. Other things that are more associated maybe with food poisoning or traveler's diarrhea, for the most part, some of these are self-limiting. So like salmonella is usually self-limiting. If you're ever severe illness, like with really frequent diarrhea or febrile, you could consider antibiotic therapy or even hospital admission, especially if the person's dehydrated. Shigella we usually treat with a fluoroquinolone. Campylobacter is self-limiting, but you can treat it with a fluoroquinolone as well. The really thing to remember is Cipro pretty much is a drug of choice for all of this stuff. Macrolides can work too, like azithromycin would be okay as well. E. coli is a tricky one. E. coli is what's probably most responsible for standard traveler's diarrhea, which is why prophylactically it's given to a lot of people when they travel. You have enterohemorrhagic strains as well that can cause significant bleeding. The issue with this is that if you give an antibiotic for this, you can lyse all those cells, which causes an increase of toxin release, causing more bleeding and more problems. So anything that's causing bleeding, you probably just want to treat with supportive care, replace fluids, even replace with blood products as needed, but you don't want to give them antibiotics for those specific cases. You can do testing to isolate these specific strains too. UTIs, E. coli, almost always going to be the bug we're treating here. And you really have to break it down towards what symptoms are we looking at. Are we looking at a basic UTI with just dysuria, urgency, frequency? Elderly patients might present with some altered mental status and not necessarily specific urinary symptoms. And then pyelonephritis and more systemic illness would be marketed by flank pain. That would be a slightly different treatment strategy. Big important thing is that we don't treat asymptomatic bacteriuria. The exception would be pregnant patients, patients undergoing traumatic urological interventions, or those just deemed really high risk. Maybe they're immunocompromised or something like that, and you want to treat them anyway. But generally, somebody doesn't have symptoms, and for some reason you decide to culture their urine, just don't treat it. And first of all, don't get the culture if they're asymptomatic, but it happens a lot. Contamination versus colonization versus infection. So was the sample contaminated? Was it a good clean catch urine specimen? Is the patient colonized? Have they had 20 cultures in the past year because they're catheterized and they have this colonization of some bacteria, or is it actually an infection? That's a clinical judgment call to learn as you practice. And then, of course, E. coli is the biggest culprit here. Other things that can cause it: Klebsiella, Proteus, Staph saprophyticus is a common one for young, specifically sexually active females. It's a common source of UTI. It's treated pretty much the same as E. coli, though. All these are really the same treatment, which is nice. For basic UTIs, there's 4 options: nitrofurantoin, Bactrim, cephalexin, and Cipro. You can see the courses there. So the Bactrim and Cipro courses have the advantage of 3 days. However, they're also the highest resistance. Bactrim is probably about 20% resistant. Cipro is probably about 15% resistance in the community. So empirically, I like macrobid or cephalexin better, just because you're going to get better coverage rates with those agents. But you do see the other two. I would probably avoid Bactrim empirically, but Cipro, sure, you could still use that empirically. That 3-day course is nice. I do see a lot of resistance to that in the community, and it's a noted thing on our antibiogram. You want to follow the cultures, adjust as needed. For sometimes you get people who have allergies to things and they have resistance, so you could consider a 2nd or 3rd generation cephalosporin. For pregnant patients, macrobid and cephalexin are 2 drugs that work great. Macrobid actually has some issues in first trimester pregnancy, but after that it's fine. Cephalexin is the preferred drug in pregnancy. For complicated patients, we consider complicated. Any type of male patient would be complicated. That's because the male anatomy is a little bit different, of course, and with men, you can't always rule out a prostatitis when you're looking at possible urinary tract symptoms. And the reason why that makes it different is because certain drugs don't get into the prostate gland very well. And we like to use Cipro for that. So nitrofurantoin really gets into the urinary tract and the bladder. It doesn't really go anywhere else. It doesn't affect the kidney tissue. It doesn't really get anywhere. So for male patients, it's a no-go in most cases. Usually for complicated patients, pregnant patients, male patients, chronic catheterization, besides what I just said, you're going to treat them a little bit longer than the standard course, and maybe higher doses depending on what it is you're treating. Pyelonephritis is the same pathogens you're looking at, but more serious. Again, macrobid nitrofurantoin has poor kidney penetration, so you aren't going to use it at all. Beta-lactams have poor kidney penetration, but you can use them. You just want to extend the course. Fluoroquinolones they spelled fluoroquinolone wrong. Bad pharmacist. Fluoroquinolone. Are our first line here. So despite the fact that I just told you Cipro has 15% resistance, it still becomes a first line agent for pyelonephritis. So our general strategy is give IV IM ceftriaxone times 1 dose. That's something you can do in the urgent care ED you work at. If you don't have access to those types of medications, you can just start them right on Cipro. And oftentimes they'll use ciprofloxacin or levofloxacin for 5 to 7 days for pyelonephritis. If you don't do IV or IM ceftriaxone, you do have to extend your course a little bit longer. So you'll do like 10 days of Cipro or up to 2 weeks of it. So the IV IM ceftriaxone buys you some time right away, and it gives you a synergy with the fluoroquinolone. Bactrim, cephalosporins can be used, but you're doing a 14-day course. And cephalexin, I just put this dosing on here for your reference. I don't ever test you on doses, by the way, but with ceftriaxone, you have with the exception of a few things, I'll just give that caveat, but I'll tell you very specifically if I'm ever going to test you on a dose. But cephalexin is dosed twice daily for a uncomplicated UTI and 4 times daily for a pyelonephritis or a complicated UTI. Pregnancy, cephalosporins are the preferred therapy. All right. Here's a funny propaganda poster. I'm not sure if this is real or somebody just made this up, but it's from the World War II era about being careful not to have good time girls or prostitutes and pick up syphilis or gonorrhea. You can't beat the axis if you get a venereal disease, right? So bacterial STDs are chlamydia and gonorrhea. So I just told you don't have to know doses unless I actually tell you that. And this is one of the few cases in the entire course series where I do want you to know doses. I just see this done wrong a lot, not necessarily with the azithromycin, but the ceftriaxone. So I think it's really important to know this. And you're going to see STDs in any realm of practice. So I just think that this is a good thing to have memorized. Chlamydia, or Chlamydia trachomatis, is treated with azithromycin 1 gram orally times 1 dose. And gonorrhea is treated with ceftriaxone 250 milligrams intramuscular times 1 dose. Plus, you want to treat with the chlamydia treatment as well. So the difference here is that if you just test positive for chlamydia, you can just give azithromycin. But if you test positive for gonorrhea, you give the gonorrhea treatment plus the chlamydia treatment. And that's because you get some synergy. We've seen some growing resistance rates with gonorrhea. And because sometimes you can test positive for gonorrhea and not necessarily pick up the chlamydia. So it's worth treating there. Trichomoniasis is another parasitic STD. And metronidazole 2 grams 1 time for 1 dose is a common treatment for that. So if you're getting the gist of this, you understand that this is a one-time doses for everything. The nice thing is you're ruling out adherence issues with the exception of doxycycline. So there is some data actually that says that doxycycline is probably a more effective drug over 7 days than the azithromycin 1 gram one-time dose, but it's not that much more effective enough for us to want it over azithromycin because of the compliance issue. People may not finish the 7 days. They will finish a 1-day course, hopefully, right? Unless they don't take it at all. Bacterial vaginosis isn't really an STI. It could be, but you can treat that with metronidazole. Usually that's a 7-day course. You can also treat it topically with metronidazole gel. It's a product called Metrogel. Syphilis is a different story. So there's primary, secondary, and tertiary syphilis. Primary syphilis is usually a 2 to 3 week incubation period. It presents with a chancre ulceration, which is supposedly painless. It's like a canker sore looking thing. But by the time you see this, the bacteria is usually widely disseminated. Secondary syphilis is about weeks to months after the chancre appears. It's the nickel and dime rash, and it has different severity aspects to it. You can lose your hair, have musculoskeletal involvement, and GI and neurologic involvement. And late syphilis is cardiovascular involvement and neurosyphilis, which can have acute aspects to altered mental status. It can also cause some psychosis-like symptoms too. Al Capone was notorious for dying of syphilis. Syphilis is a spirochete, which I found this really cute, like stuffed syphilis thing, which is gross, but also, yeah, anyway, I found that on the internet. But it looks like that, and the spirochetes can get all over the body, and they cause different, I don't know, they make sores in different areas, so in the heart and the brain. It takes them a while to get there, but it is a very deadly illness if you don't treat it. Early treatment is very simple. The syphilis responds really well to penicillin. So high dose IM penicillin times 1 is fine. Latent or unknown duration of patients. So if somebody comes in and they've had syphilis symptoms for a while, you want to repeat that high dose for 3 weeks. So you get 3 doses of it instead of just 1. Alternatives for syphilis are frowned upon. We use penicillin and penicillin alone, but you could possibly use these other things. Syphilis is one of the things where people actually get desensitized if they're allergic to it. So you'd go through if you're allergic to penicillin, you would go through a desensitization protocol to get the right treatment, especially if you have latent syphilis or neurosyphilis. Neurosyphilis, we skip the IM shots and we do IV penicillin, high doses, 10 to 14 days. And again, there could be alternatives that work and likely are, but nothing's been studied or documented because no one really does test studies on this stuff anymore. So we don't really know, but we know penicillin works really well. So we still use penicillin as a drug of choice. Sepsis can be really anything. It's a critically ill patient that's going to be characterized by either some form of infection and organ damage. And you could have a bacteremia, you could have a local infection you could have a urinary tract infection that causes sepsis, you could have a pulmonary infection that causes sepsis. You don't necessarily have to have a bacteremia, but oftentimes they go hand in hand. Septic patients get treated with broad-spectrum antibiotics regardless of the source. Usually we treat them very aggressively right off the front bat, and then we'll do blood work and microbial testing to make sure that we're treating that appropriately and we can narrow as possible. But it's a fast treatment, and you treat it aggressively. There's a lot of really good data that shows that the faster you start antibiotics in a septic patient, the better the outcomes are. So we have it's a big deal to get your lab work done and to get your blood cultures done before you start antibiotics, but you don't want to delay antibiotics too much. You want to get them done really quickly with a septic patient. We'll talk about that a little bit more during our critical care module, a little bit more about sepsis care and fluid resuscitation and things like that. But this is basically the gist of treating a bacteremia or sepsis. You treat broad spectrum until you know exactly what you're treating, and then you can narrow after that. This is just sepsis and what the definition is. So there's SIRS criteria, temperature, respiratory rate, heart rate, white blood cell count. Sepsis requires 2 SIRS criteria plus suspected infection. Severe sepsis is the sepsis criteria plus end organ damage, and septic shock is hypotension. And then usually that's unresponsive to fluids as well. So you're giving fluid boluses, patient's not responding, end organ damage. So an end organ damage with a septic patient would be like evidence of acute kidney injury, cardiovascular complications, neurologic complications, things like that. Because you basically have this inflammation. Your body's in this inflammatory response. So your blood pressure is dropping because your blood vessels are all inflamed and you aren't able to keep pressure up. So you end up with infarction in end organs. So kidneys specifically and brain can be severely affected by sepsis. Some other random diseases, tuberculosis. Tuberculosis can be really complicated, and all I would ask you on the exam is to recognize a tuberculosis regimen. So if I gave you that drug regimen for an initial tuberculosis, I would expect that you could recognize those drugs as TB drugs. That's really all I care about. Basically, you treat with these drugs. And notice we talked about rifampin briefly, but we haven't talked about any of these other medications because they aren't really used anywhere else in medicine. But you take all 4 agents for 2 months, and then you take just isoniazid rifampin alone for 4 additional months, and then there's a second option there. Tuberculosis is kind of interesting if you ever get involved with international medicine or tropical medicine or anything like that, where there's countries that are endemic with tuberculosis. We don't have a lot of it in the U.S., but you might get patients coming in on it. You do actually want to have directly observed therapy. What that means is that you want to observe the patient taking the medication. So somebody takes the medication, you need to be there. It's almost like if you've ever heard of a methadone clinic for drug abuse, people will come in and they'll take their methadone in front of somebody. That's exactly what this is too. And the reason is that there's actually evidence that shows that that's a lot more effective than prescribing it to somebody and making them take it, because tuberculosis can be serious. We want to eradicate it. We want to make sure it's treated appropriately. And this is required for that to happen in most cases. There's a lot of other options, like the more standard drugs we've talked about, like fluoroquinolones, that can be used for resistance or other cases, but I'm not going to get into that because that would be definitely a specialist type of a thing. Lyme disease is really common in Minnesota, especially in the summer months, fall months, spring months, and it's of course a tick-borne illness. The bug is Borrelia burgdorferi, and the common presentation is this erythema migrans, which is a target-like symbol. It's a spirochete, kind of like syphilis, so it actually has a presentation and pathophysiology similar to the way syphilis presents. Doxycycline is the common drug that's used, and it's pretty much the only one that we use for these patients. So it's 100 milligrams. Usually twice daily for 10 to 21 days. You can use amoxicillin and ceftriaxone as alternatives, but this is another one where we really like just doxycycline. And just as a interesting side note, when I talked about doxycycline not being ideal for kids and tetracyclines not being ideal for kids because of the gray staining of the teeth, for a variety of tick-borne illnesses, actually they still use doxycycline a lot in kids because it's so effective. And they've found studies that show that it really doesn't cause any issues with teeth per se. So we don't know how much of an effect that is. So we don't use it in kids if we can avoid it, but it's certainly something that is the standard of care, and we do use it when we have to. And remember, this is deer ticks. So if you don't know anything about ticks, I would look at the difference, because you may get questions now that you're a soon-to-be PA. You're going to get questions from your family like, "Oh, I had a tick on me. Do I have to worry about Lyme disease?" It's like, well, what type of tick was it? That's very important. Lyme has an advanced disease component to it too, just like syphilis, and it can be neurologic affecting and cardiac affecting. You can get arthritis too, that can be long-term effects as well. But basically, you're going to treat with doxycycline for the most part for most patients. Now, if you get a really serious infection, especially neurologic, doxycycline doesn't penetrate the central nervous system as much. So this is where we break from the syphilis mantra of penicillin, penicillin, penicillin. In this case, we can use ceftriaxone, which gets into the central nervous system really well and is quite effective at treating Lyme disease. So that's the last slide. The one other caveat I'll have about Lyme, because I see this come up every once in a while, is this idea of chronic Lyme disease. So there's no evidence that there's a chronic infectious component of Lyme disease. Certainly there's possibility that people who've had Lyme disease can have lasting neurological issues, but the idea is that the bacteria will be eradicated over a certain amount of time, and it doesn't do any good to treat it ongoing. I have had people come into the hospital on these really strange regimens where they're taking like really high doses of fluoroquinolones and getting IV cephalosporins at home like 4 days a week out of the week for months at a time. It's really weird. It's probably bad medicine, but in case you see that come across, that's not a medically sound thing, and very few infectious disease providers will actually do that, and ones that are legitimate will certainly not do it. So other things you consider with Lyme disease, ehrlichiosis is another tick-borne illness which could present similarly. So I just want to throw that in there. It's treated fairly similarly as well with doxycycline. All right, that concludes this lecture. I'll see you guys on the 11th.